Good morning, everyone. Thank you very much for having me. Thank you for the Sister Symposium with Galen. What is Galen? Who is Galen? It's the Global Allergy and Asthma Expert Network, and you may know Galen mostly because of its core, its centers of reference and excellence, like UCare, ACare, AdCare, AnaCare for urticaria, angioedema, atopic dermatitis, and asthma. We're very happy that you invited us to bring you news on some of our favorite diseases, and I will start with urticaria. Who of you sees patients with urticaria? Let me see your hands if you see patients with urticaria. That's almost everyone. Excellent. We will keep the introduction short then and focus on the news, but I want you to remember that urticaria is itchy wheals, angioedema, or both. In most patients, actually, it is both. They have wheals and angioedema, and we have to bring that on board in our treatment scheme. We have to look at the wheals, we have to look at the angioedema, and minimize the burden that comes with those two signs and symptoms. We will be talking about chronic urticaria. Acute urticaria solves itself. We don't have to worry about it much, but once it becomes chronic, it's a devastating disease. And it comes as spontaneous or inducible. You all know that. I'm just reminding you that there are actually quite a lot of patients who have both spontaneous and inducible urticaria. It's a female disease. We know that. 7 out of 10 patients with chronic urticaria are female, and it can hit anyone, from really young to really old. This disease doesn't care. It's mostly middle-aged people who get this, but it can hit anyone. And if you still think that it is rare in children, you are wrong. It is not rare in children. This is a recent study from 5 European countries, and you can see that the prevalence in the age group 0 to 17 is 1.4%, which is about the prevalence of chronic urticaria in the adult population. My country a little less, in some countries a little more, but certainly not less than in adults. So let's keep that in mind, and let's also keep in mind that this is a really stupid disease to have. Really stupid. Patients come to us, they often don't have anything to show for, because the wheals were there, and they will be there, but they're not there when they sit in front of us. And that's not good for us to understand how bad it is. And I always ask them, show me your last picture on the phone. Always, always, always. When we look at the quality of life impairment of this disease, and these are skin diseases, same is true for other allergic diseases, it always is one of the worst ones to have. Itch is horrible. You know, people used to say it's the little brother of pain. They are at least twins. No, and to have itch will occupy your mind and let you think of nothing else but the itch. No? So let's keep in mind that these people don't sleep well, don't function well, don't feel well, and really need help. This will be important when we talk about the new treatment options that we will focus on. People don't sleep well. We looked at it, and we found that most of the days of the week, most urticaria patients do not sleep well. And when I don't sleep well, I don't know about you, things are stupid. No, the day starts bad because I'm tired all day, I can't function, I'm in a bad mood, and that perpetuates every night that you don't sleep well. And you can see here that many patients don't sleep well on most days of the week. And it's a long-standing disease. Yes, some patients have this for 3 months or 3 years, but on average, it's 5 to 7 years. And I see patients who've had it for 20 years, 30 years. Hard to predict how long patients will have chronic urticaria. They have to be ready to deal with this for a long time. We have to be ready to help them with this. I'm setting the stage to remind us all that this is a stupid disease to have, very complex, very frustrating, often uncontrolled, and severely disabling. So we have to think about the need to treat. Is there a need to treat? Absolutely. We cannot leave our patients running around with their wheals, with their angioedema, because we know what it will do to them. So let's think about what we can do to help people. And there will be a fantastic lecture later on our standard So I will be short on here. Just to remind you, we know the causes of chronic spontaneous urticaria, and it's autoantibodies. It's IgE antibodies, autoantibodies to autoantigens, that's autoallergy, or it's IgG antibodies to mast cells activating them. And I always tell my patients, you have this because you're allergic to yourself, because your immune system is working against your own body. Because what do they think? They think they have an allergy. 9 out of 10 patients come to me and they say, Doc, what am I allergic to? Why is this happening? Do the right test and tell me what I'm eating, what I'm breathing, what I'm allergic to. And that's not the case in most of these patients. Most of these patients have autoallergy and autoimmunity. That's the underlying cause. And most patients, but not all, experience exacerbation of their disease because of specific situations. And I talked to them about 3 of them. Aspirin, ibuprofen, diclofenac. Those are, in 3 out of 10 patients, exacerbators of the disease. Viral infections. Get vaccinated. Yes, vaccines can also exacerbate disease, but it's much less common and much less severe than with the actual infection. And COVID taught us a big lesson here. And stress. Stress in 3 out of 10 patients is a trigger of exacerbation. While I tell them I cannot prescribe you a stress-free life, it is valuable to tell them that this is something that can make it worse, just for them to understand what's going on. Triggers, not cause, triggers, and the underlying inside pathology that drives the disease. And this is also good to know because now we will be talking about the treatment options we have and the ones we will get very soon, addressing our knowledge of the pathogenesis of chronic spontaneous urticaria. Treat the disease until it is gone. My favorite sentence in the guideline because it makes very clear we should not fall short of making patients free of signs and symptoms, providing them with complete control. That's the goal. To do that for as long as it takes until the disease goes away. How do we do that? Well, we look at their symptoms, we look at their control, we look at their quality of life. And when we have an overlap of perfect response in these 3 areas, bam, we have hit our goal. That's what we want. That's what we're shooting for. How do we do that? We have guideline recommended treatment options. You all know this, and you probably all have your favorite non-sedating antihistamine, which you updose when it doesn't work. And you all know, I don't even have to ask you, that this does not work in everyone. There are patients who are resistant to antihistamine, even at high dose. And many of you use omalizumab, anti-IgE, to help these patients. And many of you also use higher than standard doses, in line with the guideline. Now, in order to do this right, we need to have a compass. And the compass is our urticaria control test. Don't treat patients without the urticaria control test. When there's less than 12 points, it's a call to action. When there are 12 points or more, we know we're on the right track. Where are we going? We're going to 16. We don't stop before we hit 16. Once we have 16, we know our patients have controlled disease. We can relax. They can relax. Now we can move forward with a second principle. First one is treat the disease until it's gone. Second one is with as little as possible. As little as possible. But keep control. This is now done with cruise. How many of you have knowledge of cruise? Many of you know this? Wonderful. Okay. This is a new tool, 1 year old. More than 10,000 urticaria patients are already using this globally. So it's a really nice way for us and for our patients to keep control of their disease. The urticaria activity score is in here. The urticaria control test is in here. Also the angioedema tools. So we are well equipped to measure the need to treat and the response to treatment. Now, let's be really short here. Do not change the antihistamine when it doesn't work. There's no use. Do not combine. Do not use cortisone. Do not use leukotriene antagonists. None of this is recommended. Go up in your favorite antihistamine to fourfold the dose. And if this doesn't work, go to omalizumab. And omalizumab we will hear a lot more about, so I will be very short just to show you that in autoallergic CSU, omalizumab is great, fast, very effective. In autoimmune CSU, not so much. No? So we need better treatment options across the board, but especially for autoimmune chronic spontaneous urticaria. That's the one that comes with the IgG antibodies that activate mast cells directly. Okay, now let's look at what we can do so far for those people with autoimmune, but at least we can diagnose them. If we look at IgE, specifically low IgE, and patients have this, well then we have a good marker of autoimmune chronic spontaneous urticaria, and we can pay special attention to these people because they are at risk of not responding to an antihistamine, not responding to omalizumab, needing more advanced treatment. Okay, wow, what a picture. We have been able to show such a picture 10 years ago. 10 years ago, this would have been a mast cell with a bit of IgE and a bit of histamine coming out of it. All of what's on this slide is knowledge generated during the last 10 years, showing that there are many receptors on mast cells that contribute to their activation, that these receptors, when activated, engage inside molecules, signal transduction molecules, that translate the activation to degranulation and the release of other mediators. And mast cells making use of basophils and eosinophils, calling them to the site, to the skin, and this is all driven upstream by cytokines and autoantibodies. So with this, we can now start to develop better treatment options, which is exactly what we're doing with our partners in industry. And we have 4 ways of thinking about this. It's always the mast cell in the skin that makes our patients sick. We know that. There's no urticaria without mast cells. So what can we do? We can go and tell mast cells, well, whatever you're releasing, we're going to stop it. And this is inhibition of mast cell mediators, like we do with an antihistamine. Mast cells release histamine, we stop the histamine with the H1 receptor antagonist. One concept, but it only stops one of the mediators being released. Second, more powerful concept, we inhibit the activation. Think of the IgE receptor, IgE sitting on it, the autoallergen comes cross-links and activates mast cell. We can stop that with omalizumab. It's one pathway of activation, and there are others that we can target. Now, more all-comer treatments that should work in all patients, no matter what their mast cells release, no matter how they're activated, is the silencing of mast cells. You put mast cells to sleep. And the killing of mast cells, the most radical approach. Yeah, today we can kill mast cells. We can deplete humans, patients, of their mast cells and make them mast cell free. And I'll just show you some examples of what these different strategies can do. What can we do in terms of inhibiting mast cell mediators? Histamine is one of them. Okay, and we should go not against H1 only, but also against the other histamine receptors. And this is being done. More importantly, there are important cytokines produced and released by mast cells, including 4, 13, 5, 17, and 23, depending a little bit on whether it's autoallergy or autoimmunity that drives the activation of mast cells. Dupilumab is effective in many diseases, including chronic spontaneous urticaria. It's not an allergy, but it is, in many patients, a type 2 disease, and dupilumab brings down disease activity measured with the urticaria activity score, measured with the itch score, and measured with the hive score. So clearly another drug that's on track to come to us for the treatment of chronic spontaneous urticaria. Why does it work? Well, probably there's more than one reason, but one of them is, I think, the reduction of IgE levels in these patients, here after 24 weeks in about 50% reduction. So that's one of the things that dupilumab does and helps in chronic spontaneous urticaria. Let's look at an example for the inhibition of mast cell activation. We have receptors, and we have inside the cell signal transduction molecules. And I will focus on one of them. BTK stands for Bruton's tyrosine kinase. And why is that so important? Well, if you want more information, you can read this very nice, I'm not biased at all, paper that came out recently. But let me explain just in short terms, what is BTK? BTK sits inside the cell, mast cell. And when it gets activated by the IgE receptor, this leads to the activation of BTK, and BTK then causes degranulation. So imagine this one gone, then the mast cell can no longer get degranulated. That's one effect. The other effect is it sits on B cells. And why is that important? Because B cells are the ones that make the autoantibodies that activate the mast cells. So they also need BTK in order to make the autoantibodies. No BTK, B cells stop making autoantibodies. So it's a nice two-way mechanism of action, and we have two BTK inhibitors, remibrutinib and rilzabrutinib, that are currently under development. And the phase 3 trial data, so very advanced in clinical development for remibrutinib, just came out. And we see a nice reduction in one and the other study. Those are twin studies with hundreds of patients. So remibrutinib clearly works, and you can see it's also very fast. Very nice. Within 1 week, you see that most patients respond, and then it plateaus and has sustained response in these two trials. And about half of the people treated with this new treatment achieve what we want them to achieve, complete response. The other two, more all-comer approaches, silencing, work like this. Mast cells have hundreds of receptors, hundreds. No cell in your body has more receptors than the mast cell. And 99% of these mast cell receptors are activated. You engage them, boom, mast cells get activated. But 1%, very interesting percent, are inhibitory receptors. If you engage them, they do just the opposite. They don't activate, they stop the activation. Siglecs are among these inhibitory receptors, Siglec-6, Siglec-8, and there are therapeutic antibodies against Siglec-6. When they engage these inhibitory receptors, they produce an inhibitory signal so that activation is no longer possible, and this extends to many different receptors and many forms of activation. So a very nice and elegant way to tell mast cells, shut up, sit down, go to sleep, don't do what you're doing. The more radical approach is to deplete mast cells, and for this I need to make use of chronic inducible urticaria, because that was the first group of chronic urticarias where this was tried. We can measure disease activity in patients with cold urticaria by exposing them to defined temperatures. And you can see that before you treat patients here in this study, they had a very high threshold, a very high critical temperature threshold for activation. Now you give them barzolvolimab, a mast cell killer, once, one shot, and these patients become non-responsive to the cold. You can do the same thing in patients with symptomatic dermographism. No? These urticaria patients who tell you, when I'm always itchy, and when I scratch, I get even more itchy. They have high disease activity. You give them one shot, and they become unresponsive to scratching, no longer produces wheals. In fact, this is so effective that all chronic urticaria patients with cold urticaria, become unresponsive to the cold. Before they have high disease activity, you kill their mast cells, you can put an ice cube on their skin for however long you want, nothing will happen. They have high disease activity before you treat them. You treat them, you can scratch them as hard and as long as you want, there will be no wheals. So really, really effective in chronic inducible urticaria. And why? Because you kill mast cells, a 90% reduction on average, as soon as 148 weeks. Well, I looked at these people's skin in the microscope, and it was the first human skin without mast cells that I have ever seen. This is very, very new. And you can look also at tryptase, which is only produced by mast cells, and you will see how fast tryptase in the blood becomes unmeasurable because it's gone. No more mast cells, no more tryptase. Nice biomarker. Now, in chronic spontaneous urticaria, it is as effective. And it is as effective in people who've never had omalizumab as it is in people who have failed omalizumab. High disease activity, you give it in this study more than once, and you bring people down in their disease activity, you bring people up in their disease control. This is a message of hope. We will not be stuck with just 2 treatment options. We will have more. And these treatment options will work in different ways, so that hopefully, in the near future, we will have something for everyone with chronic spontaneous urticaria that works. Works because it's mast cell targeted, works in chronic spontaneous and inducible urticaria, where we right now really don't know how to help these people, is endotype specific, or can help all patients independent of what drives their disease. Many of these are in clinical development well advanced. Some of them will come to us next year, or hopefully the end of this year. And these clinical trials are ongoing, so patients who are currently not well treated should be guided to these trials. Thank you for having Galen in the symposium. This was a contribution of UCARE, the Urticaria Centers of Reference and Excellence. Can I just, out of pure curiosity, ask, who of you works at a UCARE? Who of you is a UCARE member? Okay, those are good hands. Hopefully the next time we get together, there will be more hands. This is an inclusive network. You're all welcome to join our network. If you want more information, please check out the website. Contribute to our registry. More than 6,000 patients are already in this registry. And please come to Berlin. This is an invitation to join us for the Global Urticaria Forum in December. And right after that Urticaria Global Forum, we will have the consensus conference for the update and revision of the international guideline. Greetings from our UCARE at Charité. I put my email address on the bottom right here, so if you have questions, by all means, do reach out to me. I'll be looking forward. Thank you very much for your attention.